Good morning, friends. It's indeed a privilege to have Dr. Satish Aggarwal, my colleague, for today's session.
Your student.
It's a privilege to have him. And I must tell you, you're very fortunate to have Dr. Satish Aggarwal for this presentation. We have worked together in Maulana Azad. We have been in touch with each other. One of the most sincere, one of the most hardworking, and one of the most academic surgeon that I have ever met. Today we are going to discuss about surgery on esophagus, especially under what circumstances you have to replace esophagus with various parts of gastrointestinal tract. So before we start about the surgical procedures on esophagus, what do you think won't it be appropriate to discuss about the anatomy basics?
Absolutely. I mean, basis of surgery is all anatomy only. Unless we know the anatomy of both the esophagus as well as the stomach, which is the most commonly used organ for esophageal replacement, then the whole exercise is a waste. So, yes, and who else is a better person to deal with anatomy than Professor Kakar? Dr. Kakar has always been a very strong person to emphasize on this fact that if a surgeon knows the anatomy, he can proceed. But if you don't know the anatomy, then you're not a surgeon. So I fully agree, and thank you very much, sir. You've been my teacher and you had such high words for me. Thank you so much. But Dr. Kakkar is one of the finest teachers I've ever met. And he's so enthusiastic about knowing new things about anatomy, about surgery. And so I'm really grateful to have him as my teacher. Sir, please.
Let's start. Normally, everybody thinks that esophagus is best ignored. You can't ignore this organ. Our life begins with this because if we can't keep up our nutrition, you can't survive in this world. Both for physical, the mental, and the social development, you need a good nutrition. And without normal esophagus, you can't have a normal nutrition. I'll start with anatomy of esophagus. We all know it is about 25 centimeters muscular tube which starts in the neck at the level of C6 and travels across thorax into the abdomen, and the last segment of esophagus, which is the shortest segment, about 4 to 5 centimeters, is intra-abdominal. The peculiar features of this tube are the upper 1/3 of this tube is a skeletal muscle, and lower 2/3 is a smooth muscle. But the whole esophagus behaves like a smooth muscle. Though it is a skeletal muscle in its upper 1/3, but it behaves exactly like a tubular smooth muscle. We all know about the anatomical relations. It's deeply situated, not accessible to physical examination. To assess anatomy or the physiology of esophagus, you have to take help of investigations and endoscopic procedures. The important components of esophageal anatomy, which is relevant to surgical point of view, are, unlike rest of gastrointestinal tract, this has no serosal layer. Mind you, it is very, very important. When it comes to healing, if you don't have serosal layer, if there is a minimal breach, it straight away spills into the mediastinum or to adjacent pleura and creates problem, and one has to be very, very careful. This is one of the part of the gastrointestinal tract which is minus is serosa. The second thing to remember is the blood supply. This is one part of gastrointestinal tract which has got no arterial plexus, submucosal arterial plexus. All the vessels, they are and arteries, though they don't anastomose with each other. And this blood supply is segmental. In the neck, it is inferior thyroid artery. In the mediastinum, they are the branches of aorta or the bronchial branches. In the abdominal part, it is supplied by branches of celiac plexus, that is the left or the spleen, left gastric artery or the splenic artery. This has to be kept in mind because of this typical nature of segmental blood supply, a resection and anastomosis of esophagus under most circumstances is not feasible. Dr. Satish told me just about 5 minutes back that cervical part of the esophagus has got a submucosal plexus and has very rich in arterial supply. So you can mobilize the cervical portion of esophagus, but you can't mobilize the thoracic or mainly the thoracic. The abdominal part also has a rich blood supply, but this is the portion, the thoracic portion is the one which you can't mobilize and resect into anastomosis.
And that's more so in scenario of esophageal atresia and tracheoesophageal fistula, where congenitally the esophageal continuity is disturbed. So the upper esophagus gets distended, muscular, more muscular, and because it has a supply from thyrocervical trunk from above, the blood supply is coming from the neck. So while you are working in the chest, you can mobilize the upper pouch, but not the lower pouch. Lower pouch has a very treacherous blood supply, segmental blood supply, and arteries. The moment you start mobilizing, it turns blue. But the upper pouch is muscular and you can stretch it because it has somewhat, submucosal plexus. Yeah, that's very important for surgery for esophageal atresia.
What is surprising is it has a segmental blood arterial supply, but the venous drainage is very, very, you say, much more developed like lymphatic plexus. The lymphatics of esophagus, they go into the neck, that is cervical lymph nodes. In the thoracic part of esophagus, it goes into the mediastinal lymph nodes, the bronchial lymph nodes, and in addition to just being into the thoracic lymph nodes, lower 2/3 of esophagus, the lymphatics drain down into the abdomen, goes into the celiac and the lymph nodes or lymphatics along the stomach. That is why it is worth to remember, I repeat, it has got no serosa and its blood supply is segmental and the vessels are and arteries. Now we'll come straight to what are the indications of esophageal replacement. I'm not going to go into the physiology because there is no end to it to which we can go on. Basically, esophageal replacement is required if congenitally there is atresia with or without fistula. Amongst the acquired, it's not caustic, it's caustic, caustic, caustic strictures caused by liquid